Good afternoon. Welcome and thanks for joining us for today's HIS Talk webinar, Analytics for Population Health, Straddling Two Worlds. It's brought to you by HIS Talk and presented by Chilmark Research. I'm Lori from HIS Talk and I'll be moderating. In today's webinar, the Chilmark Clinical Analytics team will be sharing some of their key findings from the recently released 2016 Analytics for Population Health Market Trends Report. I have a couple of housekeeping items to make you aware of before we start the presentation. Attendee phone lines have been muted to prevent background noise. Please use GoToWebinar's question box in the console to submit questions to our presenters at any time. The presenters will answer your questions during Q&A at the end. Today's webinar is being recorded, so you'll receive a link to the recording as well as a PDF version of the PowerPoint presentation. We have two speakers today. First, we'll hear from Brian Murphy. Brian has worked in the IT business for over 25 years and currently serves as a lead analyst for all matters relating to HIE and interoperability at Chilmark Research. Joining Brian will be Jodie Rank. Jodie is the senior analyst at Chilmark Research, where he's looking at how HCOs are implementing analytics tools with a specific focus on how they will be able to realize value from their investments. With that, I'll turn it over to you, Brian.
Thank you very much, Lori. On a personal note, I just want to tell you what an honor it is to be participating in an HIS Talk webinar. I've been reading HIS Talk so long that I can, at this point, no longer remember a world without it. So thank you very much for having us. As Lori said, my name is Brian Murphy. I am joined today by Jodie Rank. We are both analysts at Chilmark Research. We're located in Boston. We are a market research company that does nothing but healthcare IT. Our theme today is straddling both worlds. And the two worlds that we're talking about here are fee-for-service and its alternatives. Fee-for-service, I think, as most people know, continues to kind of hold the industry in its grip. It's still the dominant way that providers get paid, but the type and variety of alternative payment systems just keeps on proliferating. All providers obviously are still involved in fee-for-service, but most providers at this point are also involved in some kind of alternative to it. And it's certainly true that the cohort of HCOs that have no involvement in alternatives gets smaller every month. The analytics products that we're going to talk about today exist to help HCOs get a handle on both of these payment worlds. HCOs are using these products primarily for revenue assurance and secondarily to improve care, and we think that's upside down. We think that the potential for these products is essentially not really tapped, and that those two purposes ultimately are going to have to switch position. That is, HCOs ultimately are going to be using these primarily to improve care and outcomes and things like that, and secondarily as revenue assurance tools. So when you look at kind of the range of things that are being done with these products and compare it to the range of things that could be done, there's plenty of opportunity left. And in order to kind of take advantage of those opportunities, we think that the industry collectively is going to need to address some challenges, some obstacles that are kind of partly systemic, partly cultural, partly as a result of entrenched interests, and partly as a result of these products themselves. So you're looking at our agenda today. So Jodie's going to start out, and he's going to provide a kind of a snapshot of the market in terms of what's driving demand, and talk about what we see as a good way for providers to kind of conceptualize and think about the data that they use for these kinds of applications. And then I'm going to take over and talk about how these products are being used and give you our take on what we see as kind of reasonable next steps in terms of these applications. And at the end, we're also hoping to get some real questions. So at this point, I'm going to turn it over to Jodie.
Thank you, Brian, and good afternoon, everyone, or good morning, depending on where you are. We could pull up okay, we have our first slide. So as Brian alluded to, we're really looking at how the rise of these alternative payment mechanisms are shaping data analytics offerings, particularly for population health management in the coming years. And just to give you a quick, brief overview of what some of those alternative payment mechanisms include would be the Medicare Shared Savings Program and Pioneer ACOs, which need to assess a number of benchmarks associated with quality and performance that cover everything from HCAHPS, patient satisfaction surveys, patient safety prevention, and care coordination. Also have DSRIP, the Delivery System Reform Incentive Program, which has provided about $30 billion for triple aim outcomes, and really puts an emphasis on care management, primary care, quality of care, access to care, and so forth, across a number of the most important chronic diseases that also include HIV, AIDS, obesity, asthma, and the like. We're also looking at episodic bundling payment mechanisms that include the bundled payment for care improvement and comprehensive care for joint replacement initiatives. Both of these really, you really have to think a lot about coordination of care, analyzing both in and out of network care, and keeping tabs on that in order to thrive financially. And so a lot of the data analytics offerings will, in this area, will be looking at referral management and so forth. And just to give you some idea of where the market is in terms of these alternative payment mechanisms, HHS has targeted 50% of contracts by 2018 under these APMs, and we've already seen about 40% of states implemented 5 or more alternative payment mechanisms last year. If we go to the next slide, there are a number of challenges associated with these APMs so far. One is the proliferation of quality measures across payers, and then we see this phenomenon of many of the medical societies coming out with their own payment mechanisms. So this has increased the reporting burden that providers have to comply with, and also sparked a major discussion over what are the quality measures that matter most, and which measures would actually matter for patients if we're going toward patient-centric care progressively over the next few years. We've also seen patient-reported outcomes tracking is rather weak overall in the market. And then one of the big challenges right now is that providers, this new world of value-based care, most providers don't have a lot of experience assuming risk, and they lack the internal cost data to really help guide them through some of the contracting mechanisms. And this is also exacerbated by some of the very heavy reliance on claims data so far that delays of 30 to 90 days in many cases. These are all holding back the ability to provide the analytics in real time that you can really thrive in value-based care alternative payment mechanisms. If we go to the next slide. There are a number of technology challenges associated with this as well. The HIE really aren't up to the task of providing the data we need in real time. And we also have issues, there's a lot of talk in the market about FHIR and its impact on interoperability, but these are still the early days, and we still have quite a ways to go before FHIR really has a major impact in the analytics offerings in the market today. Many organizations are also really bogged down with the extraction and integration of data across providers and networks in order to get an accurate view of the populations of cohorts and patients under their care in providing the quality and outcome measures that they need to perform to these contracts. This is also held back by just some of the skepticism and wariness of the cloud in healthcare, but we are beginning to see that's definitely beginning to change. But healthcare does lag behind other sectors of the economy. If we go to the next slide, please. So where is the market overall just in aggregate around the data analytics offerings? One of the issues we're surfacing is that very, very few healthcare organizations actually have a robust data governance strategy in place. And we're looking at some of the organizational issues that need to be addressed in order to move the market much more quickly, and we think this is a big one. And also rethinking the traditional role of the CIO, and we are beginning to see more chief analytics officers, but the prominence of analytics within value-based care is, we're going to have to take both of these issues much more seriously. Tools that we are using is risk stratification, and most of the risk models that we've seen in the market came into being with the payers prior to population health management, so we do expect to see some innovation around risk stratification tools, especially in this need to integrate more social data and then make the models, or at least have a more dynamic form of. And in the current market, we've seen surveys suggesting that only about 20% of HCOs actually have the capabilities in place to do predictive modeling in a very robust manner. So we go to the next slide. So taking all these issues into consideration, at Chilmark Research, we're going to be coming out with a paper, a model for, or a framework for a health data value chain that we think would be rather useful and helping organizations actually realize that the goal of becoming more data-driven organizations. And the health data value chain that we've developed begins with data governance and ethics and getting all the stakeholders across all of the various functional areas of the organization in alignment over their health data analytics needs, and then work from that to develop your methodologies and approaches to everything from data management and curation to clinical or diagnostics, clinical and decision support, to population health management, and then even further downstream to clinical research, and really try to get the entire organization in alignment around the offerings that are out there and what are your data needs and the work of clinical and non-clinical or operational workflows, and sort of mapping this out so that you can have greater efficiencies and realize more value in your return on investment in your data analytics offerings. But all of this is driving towards this triple aim essentially that value-based care demands, with improved outcomes, lower cost structures, margin improvements, population health improvements as well. So if we go to the next slide, please. And that report will be coming out quite soon. Some of the insights we have from that work is that we did find that these, as we mentioned, the data governance and ethics approaches are still rather weak or immature at the moment. Lots of bottlenecks around the sort of just the health data value chain, and beyond just prior to doing your data analytics, but just integrating the various data sources and curating data. We're still early enough in the population health management world that creating sort of the benchmarks and standards and so forth for that are still, we're still in the early days, and that also slows things down until we have a better grasp of where the overall market's going to go with PHM. So go to the next slide, please. Some of the emergent insights we have from doing the work that Brian and I did and with our health data analytics value chain, this tension that we see often with the complaint that clinicians are slow to adopt data analytics tools, and that's often blamed on the lack of integration in the clinical workflows, but we're also finding a philosophical challenge there or difference when you have a physician who looks at the N of 1 versus the use of evidence-based medicine that's looking at population health averages. And taking a closer look at that and looking at how data analytics itself can play a role in helping to mediate that difference, that when the provider needs to take into consideration the unique characteristics and social situation of a patient and make a decision on that, not just solely based on a population average. We're hearing a great deal of talk these days about precision medicine, but we feel that's still a distant reality, despite a lot of the uptick in interest in precision medicine. Also, last year was a banner year for hacks and security breaches in healthcare. I think the last several weeks I've read where on the dark web the value of a credit card record on the dark web is $1. A health record can go from anywhere from $200 to $2,000, which does not bode well for this issue going away anytime soon. We're also seeing that organizations are dealing with as they develop their analytics tools and approaches, they're in this context where they have to deal with a lot of competing data and business demands. We mentioned the number of quality measures proliferating. They also have data sources themselves proliferating, and sort of navigating these two fee-for-service value-based care frameworks. The business rules are shifting as well, and that makes it rather challenging from a data analytics perspective and getting all the ducks in alignment around that. We're also seeing that the care management rules, there's a noticeable lack of standards in how organizations go about doing that, and putting some thought into that would also be useful. Next slide, please. And as we think about healthcare becoming more data-driven or having data-driven organizations, we need to address this, really take seriously this issue with physician engagement with analytics and broaden the framework for how we're even understanding that problem. There's a design issue with as I mentioned, with not just clinical workflows, but that philosophical problem. But we do think there's a way to design data analytics for that tension between N of 1 and population averages. We need a lot more work around use or innovation around natural language processing to address just the sheer volume of unstructured data that's still out there that is not being leveraged across organizations. But we are seeing more offerings around analytics as a service in the cloud that may help address some of the bottlenecks that we've seen with data integration and curation, a number of other bottlenecks across the health data value chain that we'll get into in more detail later. And then the growing challenge is just going to be the sheer amount of non-EHR data that systems are going with. We like to remind people that only about 20% of your health outcome is linked to what goes on in the medical care system, and you have 50 to 70% that encapsulates social determinants, individual behavior, and the environment various ways beyond, and then 10% genetics. So there's a big piece of the pie that remains unanalyzed for most patients on an everyday basis, and that's going to represent a serious challenge to becoming a data-driven organization that drives those outcomes that we're interested in. And we really do believe that investing in data governance methodologies and framework structures up front can help reduce a lot of these bottlenecks downstream and alleviate some of the tensions that adoption of data analytics tools and platforms may often encounter. So there, Brian, if you go to the next slide. And you're on.
The next part of our presentation is mostly going to be about the technology itself. Our entire webinar here today is based on a report that we just published last month, where we talked to a lot of provider organizations. We talked to a lot of vendors of these kinds of products, over 30 in fact, and we kind of winnowed that list down to 21. And the reason we kind of focused on those 21 are kind of given here on this slide. These are companies that have at least 3 live providers using these products. They've got at least $1 million of revenue attributable to these products. They are also companies that providers, ask about, quite honestly. The providers that buy our reports often, they're trying to sort through the large numbers of companies that sell these kind of products, and the ones that we profiled here are names that just kind of keep coming up. Finally, these companies offer solutions that are truly enterprise in scope, in the sense that they can address the needs of multiple kinds of users, most care venues, and do it fairly cost effectively. Universally, these vendors are trying to sell these products into hospitals and health systems, but the typical solution is going to revolve around the requirements of an ACO, a clinically integrated network, and increasingly DSRIP type efforts. So as you can see, that these products are focused on the needs of HCOs that are transitioning to value-based reimbursement. The last line here is that almost universally these things are offered on the cloud. Microsoft SQL Server is nearly universally the database that powers these things, and most of these vendors are open to a variety of different pricing mechanisms, but the per member per month seems to be common to all. Another fairly common pricing mechanism would be per user per month, but PM really seems to be gathering steam. So these are of the 30 plus, almost 40 companies that we talked to, these are the ones that we ended up profiling, and as you can see, there's a variety of different kinds of HIT vendors. Our sense is that EHR vendors, at least for kind of, they to some extent have an inside lane, at least with respect to their own customer bases. These companies have also, I think, shown a fairly significant improvement in functionality over the last year or so. If you look at some of the other vendors here, the HIT vendors, the vendors that kind of come out of payers, and the independent vendors, last year at this time, I think we could say that they tended to have probably better products than EHR vendors. I don't think that you can really make that case anymore. Most of these companies tend to see analytics as kind of one piece of the overall pie. The ultimate idea here is to support population health management kinds of initiatives for the healthcare organization. And vendors in general see analytics as one of 3 kind of functional components, the other 2 being care management workflow type products, and the third being patient engagement portal type products. The role that analytics serves is to help focus attention on the part of clinicians within the HCO on patients who could best benefit from increased attention, whether that's in their kind of regular visits or through a care management program. The idea is to kind of sort through a total cohort of patients and figure out who are the people that we really need to focus on to reduce utilization, to reduce costs, to improve outcomes. It depends upon the objective. Most of these companies are also interested in better engaging patients, and I think as everybody knows, that's a difficult process, and it's not entirely clear. Nobody's really figured out an easy way to do that. But so companies are offering, many of these companies will offer kind of all three capabilities. Some focus just on analytics. There are others that focus on these, sort of patient engagement, care management. But I think most of them see this as a kind of continuous process. These are the things that people are doing today. So as I think I said in the introduction, that revenue assurance is very important. It is the and that is really in the form of generating quality reports for payers. So it's things like HEDIS, things like PQRS, meaningful use reporting, MSSP reporting. The actual applications themselves are heavily concerned with generating accurate quality reports. Closely associated with that is identifying care gaps, and obviously the people in ACO type arrangements are interested in care gaps to kind of help improve their quality scores. But most of these vendors will also talk pretty openly about using care gap capabilities to identify people that you could kind of get in for fee-for-service type screenings, things like mammographies, things like colonoscopies, well baby visits, things of that nature. So the focus is on, trying to kind of optimize revenue. These products are also very good at giving people an idea of where they're high-cost members and they're high-utilizing members. So they provide lots of information about medical costs, prescription costs, and you can see that according to all different kinds of criteria. Similarly, you can understand who's using hospitals, whether it's being admitted to a bed, or whether it's folks who are using emergency rooms who are actually lower acuity than is indicated. The other thing that these products are doing is, in addition to identifying kind of high cost, high utilizing members, they are identifying patients who could potentially benefit from a care management intervention. So this is, and I'll talk about that in just a sec. Another important thing is providing healthcare organizations an idea of where else people are seeking care. Not every vendor does this, but it's I'm guessing that by this time next year it'll be a nearly universal capability, but it's fairly common. When you look at who's actually kind of using these things, who's the ultimate end user of these applications, it's kind of a mixed picture. In general, it tends to, the people who make most use of these kinds of applications are super users, administrative users, practice managers, care managers. It's not unusual, but it's kind of your run-of-the-mill physician or nurse is not necessarily going to be a heads-down user of these kinds of products. I think that most vendors would like to see better engagement with that kind of clinical user. When you talk to the vendors, when you talk about how this stuff is actually being used, they usually present a picture of this is the kind of information that a practice manager kind of pulls together for a morning huddle. They'll put this kind of information into face sheets or printouts, or it'll be communicated out to individual physicians and individual nurses. But it's not always the case that a primary care physician is going to kind of look at this, kind of show up every morning, and this would be the first application that they open. Also, the primary way that people are using this is through portals. Almost every single vendor will integrate this into an EHR, but that, our sense is that remains, a relative minority, and that the typical user is, signing into a portal and looking at canned reports and/or dashboards. So from that standpoint, when we say that EHR vendors have kind of an inside track, the EHR vendors, I think, are probably a little bit better than some of the other vendors at kind of including this kind of application in workflow. So, it's fairly typical for them to provide quality or benchmarking reports, care gaps reports, cost utilization reports directly in, as a tab, or even, even more deeply embedded for clinical users. So, a nurse can see it, a doctor can see it. When we talk to the provider organizations and the people who actually use these things, especially clinicians, there are concerns. There's a certain level of skepticism. The average clinician, I think, believes that that opportunities for improving quality are fairly easy to find, and it isn't entirely necessary that applications like this would be the primary way that they find out about these opportunities. The other clinicians are still suffering from a fairly significant EHR hangover, and their enthusiasm about learning a new tool is probably not at an all-time high. There's also a fair amount of skepticism about whether payer-based quality reporting has anything to do with quality. Jodie mentioned kind of the number of different kind of quality metrics are out there keeps getting bigger. I think there's a general perception that this has that patients don't necessarily benefit when they act just to kind of hit their numbers. The industry is obviously aware of this problem. I think it was last week there was CMS and AHIP are supposedly going to get together and begin to sort of pare down the number and variety of different metrics that are out there. But that obviously is going to take some time. So all these products are generally built on a foundation of conventional data warehouses essentially, and the primary contributors of data are clinical data from EHRs and claims data. The EHRs, there's a kind of a mismatch here in terms of currency. Obviously, claims data is delivered monthly or sometimes less frequently than that. EHR data is often updated every night. But those two are kind of glommed together. It's to provide something that's less than a complete and total longitudinal patient record. You're not going to see every order, every result, every single med. The other thing that's missing from this is there's a lot of venues, so long-term post-acute care is generally going to be missing from here. Patient-reported outcome is going to be missing. Patient-generated data, device-type data. It's, for the purposes of these applications as they currently exist, it's not. I'm not sure that's a huge problem, but we think that looking ahead, more and different kinds of data are going to be needed if these things do begin to kind of move the needle on care quality. So I think, as I mentioned, Microsoft SQL Server is by far and away the most common database that's being used here, but there is a lot of experimentation with the NoSQL type data stores, Hadoop, MapReduce, Elasticsearch. Lots of vendors are interested in using this, and a few use Hadoop as kind of their main data store, but at this point it's really not a big player here. When people talk about things like NoSQL databases, they're talking about increasing the kind of number and type of different data types, and the sort of first advantage that they describe is that it can, it's going to let people do risk scoring better. But SQL Server, claims, and EHR extracts remain the kind of our mainstream here. Jodie mentioned natural language processing, and a bunch of companies are experimenting with this. IBM, I don't know if people follow IBM Watson Health, it's arguably the most ambitious of these efforts. The IBM Watson itself, the technology, is essentially will ingest any kind of data, clinical data, claims data, any of these other kinds of data sources that nobody is using yet could be ingested into IBM Watson. IBM is trying to figure out how to integrate its various acquisitions over the last year, and in the end it's going to provide an API, a set of APIs to this data that not only deliver the data but provide some functionality as well. Two other companies that are working on these kinds of efforts would be Caradigm and Orion Health, and they are essentially ingesting clinician notes and trying to extract concepts and figuring out how to use those in these applications. But these efforts are a ways away from being production ready at this point. The other thing that you see in the analytics market more generally is this idea of end-user self-service, and in healthcare, unfortunately, trails I think most industries here. There are a number of new products that are kind of coming on the market here, things like Tableau, ClickView, and there's others. There are startup companies that are supposedly better than them, and they provide a number of capabilities that would, I think, greatly improve the utility of this data. But at this point, healthcare is just beginning to kind of recognize the value of this. So filtered query is fairly common, whereas outside of healthcare, the ability of end users to kind of dig into their data and find patterns kind of on their own has made a little bit more progress. The other thing is in general kind of query reporting, dashboards, for the most part, are being built in healthcare by kind of super users or analysts. When you look at outside healthcare, they're using these kinds of products. End users are using these kind of products. So I think it's going to be a while before your average charge nurse is necessarily going to be in a position to dig into their data and build a program that will tell them which phlebotomists always hit the vein at 3 in the morning, but that day will eventually come. The other important capability that most of these vendors are talking about is care management, and now the analytics, as I mentioned, really serves the purpose of surfacing the opportunities. So it really provides, it lets them know who their high utilizers are, where the care gaps are, which particular diseases or episodes could benefit from a care management intervention, and the products that the workflow products that these companies are rolling out are essentially, it would be like a CRM type product meets a project management type product. These offerings are meant to be multi-organizational, so they are providing access to people within healthcare organizations, social workers, Meals on Wheels. The idea is that anybody can kind of log on to a portal and see the status of a care management intervention. And those interventions are structured kind of like this. There's goals, there's tasks, there's barriers to accomplishing those tasks. There's a whole set of assessments. There's a timeline. There's the ability to kind of add and delete care team members. These products require a fairly significant amount and variety of data. In general, these companies are kind of offering up their data, their data mart data warehouses as the place where this data comes from. But this is this is clearly a growing area. A lot of the providers that we talk to are beginning to take note of these products and are interested in finding out more about them. We are actually publishing a report on the care management market tomorrow, and that includes profiles on 22 different vendors. So if you're interested in that, please look at our website. These are some of the programs that people are using with the care management offerings from the vendors in this analytics report. It's primarily kind of geared to, again, capturing revenue and getting a handle on who the high utilizers are, but they're also being used to manage certain kinds of diseases. Diabetes, obviously, CHF, COPD, things like that. There's a lot of noise as far as being able to put together a decent care management program for people with comorbidities, but that's, I think that the companies probably need to get a little bit more experience that before those begin to really take hold. People are looking at these things as a way to keep track of admissions to make sure that Medicare patients are bouncing back within 30 days. There's a lot of interest on the part of behavioral health providers as a way to keep track of what's happening with their patients. So as we kind of look at kind of what people are doing and talking to providers in terms of kind of what's next, I think these are some of the items that sort of jump out. Right now, the view of utilization that you get in most analytics products is pretty much limited to kind of hospitalization type events. There's a whole array, a whole world of utilization out there that these products could be providing more information on. The ability of an HCO to understand, to compare similarly situated patients as they move through either an episode or a particular hospitalization event, and trying to figure out how differences in the way people are being treated generates different outcomes. The other thing that I think is missing, there's obviously a tremendous amount of attention on care gaps, but when care coordination falls down, these products are probably not great at identifying that, but they certainly could be. The other thing that is getting a lot of attention is the idea of actual internal costs, and I'm not talking about medical or pharmacy costs here. I'm talking about the actual costs experienced by the HCO. So there's interest in linking that kind of cost data to a variety of different things here. Outcomes metrics is it's a bigger topic than just analytics. I think people are trying to understand what and quantify what is a good or a bad outcome, but these are products that I think are going to play a major role in helping HCOs understand, understand the range of outcomes that they're generating. And finally, we really think that care management functionality is in its infancy, and we think that many of these vendors are going to be delivering much better functionality over the next 12 to 18 months. So these we're coming to the end here. These are the things that we are. These are kind of some high-level recommendations. I guess I'll Jodie, you still there? On these first couple items.
Sure. One of the main things I've mentioned throughout my presentation was this need to really come up with an overall data governance strategy and work with stakeholders across the organization, because we're seeing a lot of kind of point solutions and fragmentation in analytics, uses of analytics. So that, come up with those types of strategies and assigning data stewards to marshal that process and manage some of the emerging ethical issues as well are going to be quite important. If you want to talk more about the cloud.
Yeah, so cloud is has been a bit of a four-letter word in healthcare. People like remote hosting a lot better. Our sense is that when you look at these vendors, this is solid infrastructure. Notwithstanding the general fears about hacks and breaches, these companies have put together solutions that I think, that I think HCOs can adopt with confidence. Finally, there's vast areas where kind of vast areas for improvement of data discovery for clinical end users. The ability for clinical people to understand their data and really dig into it and explore it is still not entirely there when you compare healthcare to other industries. So just having an alliance with QlikView or Tableau is probably insufficient over the long term. I think that vendors really need to kind of double down on this and begin to provide better capabilities for clinical end users. So, with that, I guess we would love to receive some questions.
Okay, now we'd like to open it up to the audience for questions. As a reminder, please use the questions section on the GoToWebinar panel to submit your questions to Brian and Jodie. The first one we have, where are most HCOs in terms of building an overall data governance strategy that can help optimize analytics across population health management capabilities?
What I'd say that the best estimate I've seen is only about 20% of the HCOs in the market actually have developed an overall governance strategy across the organization. So I think, as I mentioned, we're still quite early in that movement.
Can you talk a little bit more about FHIR uptake and the analytics integration? Where do you see this in the next year?
So you want me to start with that, or?
Sure, go for it.
Yeah. So I guess my feeling on FHIR is that when you look at the use cases for that technology, it is first of all it's geared towards providing data where it's really needed, as opposed to sending email messages around with data with big attachments. But the use cases tend to be kind of patient at a time, record at a time. These applications are involve fairly large amounts of data where you're dealing with fairly substantial chunks of that data in, at any given time. So at least in the short term, I think, existing technologies like native database drivers and ODBC is more than adequate to, for, further developing these kinds of applications. Over time, I think as the use cases for FHIR become better crystallized and vendors and providers have more experience with it, it's certainly, I think it's certainly going to play a part.
Jenny would like to know if HCOs are ready or interested in measuring outcomes in support of longer-term value-based contracting.
Jodie, you want to try that, or?
Yeah, but I think that they are, but I think the issue is, we're getting back to, what outcomes matter. There's still some debate over how we go about doing that. Don't you think, Brian? That's...
Yeah, I mean, the outcome is, I think, going to be context sensitive in terms of the individual patient, and you've got a 17-year-old with a sprained ankle versus a 90-year-old with a sprained ankle. It's not, we're talking about apples and oranges. So, I think as I mentioned that the trying to kind of identify what really an outcome is probably a first-order question. But that said, the application of this technology in that process, I think is a foregone conclusion.
Gabe would like to know why you think clinicians need analytics at the point of care. When you say that most point of care providers are inundated with EMR workflow, are HCOs asking for this, or is it your point of view?
Well, this is an entirely legitimate point. The amount of data that an average EHR provides is, in many cases, way too much. I think it's fair. When I say that this would somehow be additive to that, I think that's a legitimate criticism. That said, I think that if this is sort of well thought out, and if people understand, it goes to this idea of providing the kind of right information to a clinician at a point in time when it can actually make a difference as far as a point of care decision. So I'm not suggesting that it's necessarily going to be easy, but I think that this technology definitely has a place. I think, for instance, I mean, if we just confine the discussion to this idea of care gaps, I can't help but think that if if a physician, a primary care physician, if they receive that information the second they walk in the door, they're more likely to act on it than if they had been told by the practice manager at 8 o'clock that morning that, oh, remember, such and such a patient is coming in, they have this care gap. So, I'm not suggesting that it's simple to kind of figure out how to make this, given the fire hose of information that's coming at these people, but it does have a place.
Greg points out that acronyms create distance between providers and patients. It appears the value mantra is poised to release another round of alphabet soup. Do you think this will hinder or advance value patient-centric care?
Wow. Jodie,
there's always, you also break the confusion. It's a valid point as well. We are unleashing a whole new set of those, and that adds to the already existing layer of noise and complexity in healthcare systems. So yeah, probably if we want to think about patient engagement, thinking about how we talk about the new system will take us a long way if we do something more thoughtful around that and just how we talk about what's going on.
Yeah, my mother got a letter from her health plan about offering to enroll her in an ACO, and I can tell you she had no idea what they were talking about.
The next question, what are the key differentiators that best position an analytics vendor for improving population health?
So I think one of the things that struck me about these products, and we saw demos of of the 22 vendors we have in this report. We saw demos from all of them, and our assumption is that we're getting their best foot forward. I think across the board, and I would never single anyone out. These are not the most modern interfaces. In other words, so I think that there's a fair amount of room for improvement in terms of the user interface. So that would be one area. The other would be providing non-super user types, non-analyst types, better information about the structure of the data. I think that the underlying structure of these data marts it's complicated, and the kind of run-of-the-mill user, I think could begin to take care of it, could begin to use it more effectively, but given the level of complexity, I think that's a barrier.
Do you know of any solutions that do a good job of calculating total cost of care for various bundled payment arrangements?
No. Jodie, do you have a different?
No, absolutely not.
Yeah, I mean, I think I mentioned that but BPCI, for instance, is a fairly new thing, and a lot of folks gone through the reconciliation process, so that that's going to be an illuminating exercise. When you look at this from an actual internal cost standpoint, very, very few of these solutions are in a position to kind of pull that data from ERP systems. So I think there's going to be way more interest in this going forward.
You talk about SQL Server. Do you think the old Kimball approach to data warehousing will be enough for faster, bigger data sets?
This is all sort of Kimball 101. Right now, I mean, I know that I sort of poo-pooed big data here, but the world has moved on. The wider world outside of healthcare has moved on, and when you look at the kind of the cutting edge of analytics today, they're using things like Hadoop. So yeah, but I don't really see any provider or vendor necessarily in a position where they need to move on this right now. I think there's plenty of headroom with SQL Server.
All right, this is going to be our last question since we're very tight on time. Does big data deliver any benefits to clinical and administrative users of these applications?
When you ask that question to the folks who are actually using it, the answers that you receive have more to do with their ability to manage multiple customers, to scale, to deploy new customers or new reports. In other words, I think it's it makes life easier for the vendors. It's not at all clear to me that those benefits flow in any way to end users. I'm probably going to be receiving indignant emails.
Okay, that was our last question that we have time for, so we're going to conclude the webinar. I want to thank everyone for joining us today, and thank you, Brian and Jodie, for an interesting, informative presentation. As a reminder to the attendees, watch your email for links to the recording of today's webinar as well as the PDF version of the PowerPoint presentation. We look forward to seeing you at our next HIS Talk webinar, and I hope you all enjoy the rest of your day.